Good morning from Mumbai. Today I will be talking on cervical disc replacement. Now, this was a landmark paper from Taiwanian National Health Insurance Database, which looked at more than 26 lakh patients over a period of more than 2.41 lakh years. And the end of the study that they concluded that the incidence of revision surgery in this case is due to adjacent segment disease following a ACDF was 5.6%. We know from the cadaveric study and even from the biomechanical study that adjacent segment disease following a cervical fusion is a big worry, and it can reach up to 45% at the end of 10 years. The biomechanical study suggests that the chances of adjacent segment disease is more at the proximal level compared to the distal levels. Now, C was a 22-year female with disc prolapse at C6, C7 with a decreased hand grip on one side. And if you look at this is the level in which is the culprit, and C has a fused vertebra 2 levels above. So the segment in between had a very high risk of degeneration following a fusion. So we offered her a cervical disc replacement in place of a fusion surgery, and now we have more than 4 years data on her, and she's absolutely doing very well. So cervical disc replacement does have a role to play, and this is not something which is not very new. It dates back way in 1966 when these ball bearings were placed inside spine to give some sort of a mobility to spine. And of course, this all failed, and we all have come a long way, and these are some of the devices which are available to us today. Now, when it comes to indication for disc replacement, you can do it for up to 2 levels for radiculopathy or for myelopathy in cases where the conservative treatment has failed. But if you look at the contraindication, they are very specific and has to be kept in mind. These are contraindicated in case of infection, if you have malignancy, if the index body of the vertebra is compromised, if there is an instability, if the posterior cervical spine has already fused, or if there is severe osteoporosis or osteopenia. Now, if you look at the indication versus the contraindication, there are more plus for ACDF when it comes to indications compared to cervical disc replacement. So your ACDF still remains the workhorse, but cervical disc replacement could be a good tool in selected cases. This is the head-to-head trial of ACDF versus cervical disc replacement from FDA database. And if you look at the comparison, the cervical disc replacement are either comparable or they are better than fusion surgeries. And when it comes to preventing adjacent segment disease, they are both evidences for against cervical disc replacement, and the jury is still out on this aspect. But there is definitely some evidence coming from literature that it does prevent a secondary surgery at the index level if you choose a cervical disc replacement compared to a cervical fusion surgery. So this is the video of cervical disc replacement, the technical video. She was a 30-year female which presented with compression at C4, C5, and if you can see from the MRI, there was a significant compression. So unlike a ACDF surgery where you keep the neck in some amount of lordosis, we prefer the neck to be straight when you are planning a cervical disc replacement. So much so that we'll take a AP and lateral shoot to confirm that before even we go for the surgery. So this is the cranial end. This is the caudal end of the patient. I'm standing on the left side of the patient, and as you can see, the incision is very wise, so much so that I have almost crossed the midline. If I'm doing a ACDF surgery, I don't need to be so judicious with my incision. I can keep it slightly small. But when you're doing a cervical disc replacement, you really don't want to struggle at all with your exposure. So you need to be very, very wise with even with your incision and even the dissection part. Some of it is what you have already seen in the previous talk for ACDF, but then there are subtle things which are very, very specific when it comes to cervical disc replacement, which I like to talk to you. So we're just confirming the levels. So and we'll just use a small marker to know if we are in the right level. So just putting the marker to make sure of that. This again, these are standard steps for any cervical spine surgery, but these are very, very specific steps which cannot be missed. Now we are just elevating the longus colli. Now, even when you are elevating the longus colli, you have to make sure that your muscles are not creeping in. You can see the complete width of the disc. That means you have exposed from uncus to uncus. These small things are very, very important so that you don't compromise on the size of the disc replacement. So we have just exposed it, and now we'll put the pins for the distraction. Now, these distractor pins will act as a guide throughout the surgery. So much so that even when I'm putting this pin, I'll make sure that they're the center and both the pins are completely parallel to each other. So each and every step I need to take a scan shoot just to be sure about it. If you're doing a cervical ACDF, you might skip some of these steps, and that is absolutely fine. But you cannot do that when you are doing a cervical disc replacement. Still, I can see some muscle creeping in, so we are making sure that we have the complete view of the disc which during the surgery, and rest of the some of the few steps, the standard steps which we do for any discectomy. So just taking out the disc, and if you can see, I have not put any distractor at the stage, and only time I'll put a distractor is when I'm taking out the PLL to get some more space while doing that. So now I have put the distractor, as you can see. And once we have done that, we'll again remove the distractor so we have the right side of the disc. Now I'm taking out the PLL. This is what we prefer. A ballpoint probe goes below the PLL. We lift the PLL and we use a knife to take out the PLL. It is very, very important in this case to take the complete width of the PLL so that we get a nice distraction at the end of the surgery, so that your implant goes in nicely. We're just removing the PLL, and there's some bleeding from the epidural plexus on the lateral ends, which is very, very common in these cases. So just trying to control the bleeding. We'll keep working and releasing the PLL till we have got a adequate decompression, because at the end of the day, that is the most important part of the surgery. It doesn't matter where you put it, cervical disc replacement or put a ACDF. So what we do is we look for the smiling dura sign. Means we feel that the dura is good enough that it looks like that the dura is smiling at you, and that is where we stop the decompression. This is what we feel is a good decompression, and we feel that dura is happy, the dura is smiling, and that is where we stop our decompression. And then now comes the specific steps for cervical disc replacement. So these steps are very, very specific and depends upon the implant which you are using. So this is the sizer. So today in this case, we are using a Medtronic's Prestige LP disc. So these steps are specific for that implant. So this is the sizer. Again, once we know the width of the disc space, the size we use the sizer even to understand the depth. And once we know the size which we want to put, we start with rail preparation. So these are the rail cutting jigs, as you can see. So these jigs, they have 4 pins which will cut a slot. two proximally and two distally. So we'll put these pins to make the pilot holes. So even when we do that, we have to make sure that these holes are completely parallel to each other. So every step you need to be sure that your jigs are in the center and then they are parallel in the lateral plane. So we'll take a shoot to make sure of it. As you can see here, the pins looks good. They are they are parallel to each other. And these small things you can miss when you're doing ACDF, but these are have to be make sure when you're doing a cervical disc replacement. So once we remove these pins, we have to make sure physically as well that the channels these pins have cut, they are parallel to each other. So as we are not using the distractor, my assistant will just track the muscle so that we can make sure the channels, which you can see the small two channels here and here, and they look pretty okay. So we'll go ahead with it. So now these are the chisel sort of thing. So they will cut the working channel for your implant to go. And this, what you do is you align this rail punch in the pilot hole and you tap it inside. Now it is very important to go all the way in, because if you don't go all the way in, your implant also won't go all the way in. So last part is where normally you will struggle. But if you have done a good work initially, if you have cut the use the rail punch to cut all the through the uh, depth of the pilot hole, then you won't struggle normally with the implant position. So we are just going through it, and once we think that we have gone deep enough, we'll again confirm the position on AP, which looks to be good. We are in center, and lateral that we have gone to the complete depth we wanted to be. And this is the type of uh, channels this chisel will cut. And again, we'll inspect that they are parallel to each other and they look like the working channels are parallel to each other. Now, we'll use the size which we have determined earlier. We'll align the prosthetic rails, the small rails which you can see in the implant, and then with just a gentle tapping, your implant should go in. You really don't need to push it if you have done a proper work earlier. And then we'll confirm in AP and lateral position about the relative position of the implant. You can ask your anesthetic to do a flexion extension view that will show the mobility of the implant and the stability of the implant. And this is the final position of the implant. As you can see here, before we close, we just make sure that there is no oozing or bleeding once we have removed the retractors, and then we'll just take the skin and the subcutaneous sutures, and this is the end of the surgery. And these are the x-rays which looks pretty good. And we also have a flexion extension view which showed good mobility of the implant, and these are the clinical images of the patient. So at the end, although one needs to be very careful while selecting the cases for cervical disc replacement, if it's done in a proper indicated case, it indeed is a good, elegant surgery. Thank you so much.